I treat both men and women because men have pelvic floor issues as well, and women most certainly do as well, as we are the primary child birthing vehicle. And so I wanted to take a moment to celebrate Physical Therapy Month, which is every year in the month of October, to promote pelvic floor awareness and let the public know about how we can be active in helping people return to optimal pelvic function, bowel, bladder, sexual dysfunction, and really just improving their quality of life when maybe in certain instances medication might not work, or you're seeing a decline in your bladder control or bladder function. It may or may not be related to as we age. It could be related to a wealth of issues and triggers. So what I was going to discuss today were um, incontinence, which is one of the bigger diagnoses that I see in the clinic, and frequency. So what that means is people will come into the office and they'll say, or they'll go to their doctor first. How it usually happens is, and they'll say, "Hey, doc, I'm experiencing more frequency recently." And so that means, and the doctor will be like, "Oh, how often are you going to the bathroom?" And it's like, "Oh, I'm going every hour or every hour and a half." And they're like, "Okay, well, you could try this medication, or you could do this medication and or see a urologist, urogynecologist, or a pelvic floor physical therapist." So we are sort of the most conservative first line defense in helping people restore optimal functional bladder function. So frequency is just going very often. And then leaking is the second most common diagnosis that I see in the clinic. So someone who coughs, sneezes, or laughs, and you leak a little. So these patients typically may or may not wear a pad. The patient may or may not have had vaginal deliveries or C-section or childbirth in general. It does not relate it to childbirth at all. Some of these patients are in their 20s, and some of these patients are in their late 80s and beyond. So I've treated everyone from a 16-year-old with pelvic floor dysfunction all the way up to my oldest patient, I probably would say would be 96 years old. And so in that range, there's a wide range of things that we can work on. And so a pelvic floor physical therapist will help
You
you
want to try the cupping?
identify
Oh god.
areas that can identify areas that you can work on to help strengthen your pelvic floor, um, improve your pelvic awareness, because a lot of times people aren't aware they even have these issues and what they're doing in their pelvis. And then restore function is our primary goal. What's important to you? How, is it a work related issue where you have to sit for a long time, where you're in an assembly line and you have to stand for a long time and you have pelvic pain, or you're an avid cyclist and you have pain in your perineum, which is the space between the scrotum and the anal opening, or the vaginal opening and the anal opening. So that just little landing strip right there in that area. So patients commonly will also complain of pain. But for today's webinar, we're just going to talk about stress incontinence, which is cough, sneeze, laugh, and you leak. Urge incontinence, which is, "Oh my God, I gotta go now, and I have to go now. There's no stopping you. Can't get the key in the door. Gotta pee." Urge incontinence. And then frequency, which is, like I said, these are the top three diagnoses I see in the clinic as a pelvic floor physical therapist. And there are little things that you can do at home to start working on this. So the first one we'll talk about is stress incontinence. So what is incontinence? First of all, it's any sort of leakage. So it can be urinary incontinence, which is urine leakage, or it could be bowel leakage. Now, everyone's always, for some reason in today's society, bowel leakage is way more disturbing for people to experience. And the minute someone has bowel leakage, they're immediately at the doctor's office. But urinary leakage, they make all kinds of things for, like, incontinence pads and all kinds of medications for. But for both bowel and urine, your primary care practitioner, a urogynecologist, a urologist, they can all help direct you to pelvic floor physical therapy, which is, like I said, the most first line defense, conservative management. Whether you're going to have surgery or not going to have surgery, whether you're going to take a medication to help or not, it can help. So today we're going to talk about urinary incontinence. So stress urinary incontinence, again, cough, sneeze, laugh, you leak. Run across the street, you leak. So what I tell patients, first of all, is when they have urinary incontinence that is more stress incontinence, is they have to think about what is it that they're doing that causes the leakage, right? So it could be, patient A could be like jumping up and down on a trampoline, which is a frequent scenario I get in my clinic, which is like, I took my kid to House of Air and we were jumping on the trampoline and I was like, oh my God, I really have this problem that I'm leaking and jumping on a trampoline. So these patients need to work on their Kegel, which is a pelvic floor muscle contraction. It's named after Dr. Arnold Kegel, which basically are the muscles that help you stop the flow of urine. They're the same muscles in men and women. Okay, so I know everyone's probably sitting in front of the computer or standing, whatever. If you could think about taking a deep breath in through your nose and then exhaling through your mouth nice and slowly. As you exhale, think about stopping the flow of urine midstream. That's sort of the cue that I give my patients to try to help them figure out where is their Kegel, where is their pelvic floor muscles, and do they have any control over it, and can they find it? Because some people can't really find it, and some people find it very easily, or they do it and they're holding their breath, right? So we have patients exhale as they find that muscle, and they hold for about 5 seconds. Okay, is everyone doing their Kegel with me? So you're gonna lift and hold and then relax. Okay, so just as it's important to engage and find that muscle, you also need to relax and drop that muscle, because again, the pelvic floor works on a spectrum. It has to ramp up and control urine, and it has to relax to release urine to come out. So a pelvic floor muscle contraction is and working and finding your Kegel or pelvic floor muscle contraction is the first step in helping urinary incontinence that is more stress related. Okay, and people are always like, well, how many do I have to do, and how do I do them, or when do I do them? Well, I always start everybody laying on their back, because that's the easiest way to kind of identify them. If you're standing up, gravity's not your friend, because it's kind of bearing down and it's pulling downward. So if you could take a moment in your day, and before you jump out of bed, you take 5 slow deep breaths and work on lifting and contracting your pelvic floor, finding your Kegel, holding it for 5 seconds, and then you perform that 10 repetitions. And then I always tell patients, like breakfast, lunch, and dinner, 3 to almost 4 times a day, you'll get in about 40 repetitions, which the research is showing that's what's going to help propel you into staying more dry. Okay, so stress urinary incontinence. So essentially, that's just one piece of the puzzle. But again, when you see a pelvic floor physical therapist, what we do as pelvic floor PT is we help you identify your Kegel, identify your pelvic floor muscles, figure out if you're using the right strategy, if you're engaging the right muscles and you're not holding your breath, using your butt muscles, tightening your abs, because those are all accessory muscles, but they're not the like deep rooted pelvic floor contraction that close the urethra off to keep you dry. So that's how pelvic floor That's how a pelvic floor physical therapist, whether you see me or you see someone in your area, that's what they can help you identify. And again, if you decide to have a surgery or you decide to go more conservatively and decide to take a medication, you still need these muscles in order to help further along both a surgical procedure and a medication. Okay, so then the second most common topic I also get is the diagnoses is urge incontinence. This is the what I call key in the door syndrome, um, key in the lock syndrome, where you get to your door and you're like, oh my gosh, I gotta go, and you can't get your key fast enough, and you might dribble, you might leak, or you might feel like you have to go so badly. The urge is such a large urge that you can't make it to the bathroom in time. Now, what to do for that? Again, step one is to identify your pelvic floor muscles. So the Kegel again, but instead of doing one long hold, there's like a super pathway from your bladder to your spinal cord to your brain, that if you did a couple of really light and quick pelvic floor contractions, like very light ones, you will delay the urge to your brain and it buys you a couple of minutes. Now, we tell patients also to get their hip muscles involved to help them stay dry when they have urge incontinence. So they are going to cross their legs, squeeze between their thighs, do a couple of what I call quick flicks, right? So 5 to 10 light, quick contractions, light, quick Kegel contractions, and don't move, because you can't. If you move, you're going to break the seal. So you need the wave of the urge to pass, and then calmly walk to the bathroom, pants down, sitting fully on the toilet bowl. Okay. And then release. So it will buy you some time. And that's how people start to work with urge incontinence. Urge incontinence has a lot of triggers. The brain is very smart, and it remembers that, like, oh, you had an accident a few months ago because you had to go so badly because you drank 3 cups of coffee and then you couldn't find your keys, and you're standing outside your door and you're like, oh great, this is happening to me. And so every time you get to that garage door to try to get into the bathroom very quickly, you might be experiencing those same feelings of needing to go. So the goal is to try to beat it to the trigger by doing some quick flicks, stopping all motion and using your adductors, which is muscles on the inner thigh. Squeeze and hold, and then calmly wait for the urge to pass. It will pass. And then to the bathroom calmly, pants down, sit fully, relax, both feet on the floor, breathe, and then urinate. So that's urge incontinence. And then lastly, the other most common diagnosis that I see in the clinic is frequency. So some people will come in and they'll say, Imee, I have a really small bladder. I'm like, okay, tell me, what's going on? And they're like, oh, well, I go once an hour or once every hour and a half. Now, normal bladders, so it's important to know what normal is, right? Can hold for about 3.5, about 3 to 4 hours. So if you're in the like 3.5, I'm like, okay, well, that sounds about right. But anything less than 3 hours, I would call a little bit frequent. And the bladder can hold about 400 to 600 milliliters of water. So if you think about, a Nalgene, like a canister of water, you can hold almost a whole bottle of that in the bladder. It can stretch to that capacity. Now, frequency is something where if you feel the urge to urinate after 1 hour, how to fix this is very behavioral. So some patients that come in to see me for frequency, I'll do a very thorough assessment, but many times it's a lot of education and a lot of behavioral management. So you would almost like potty training yourself. If you felt the urge after an hour, I would look at the time and say, oh, I just went at 8 a.m. and now it's 9 and I have to go again. So ask yourself, do you really have to go, or is it just in case, meaning you don't really have to go but you could go, or you're going because you think you may have an accident later, so you're just going to go just because. The goal is to push it out a little longer, distracting yourself, breathing, counting backwards, doing a couple of Kegels where you hold for 5 to 10 seconds and then relax. And what you will see is that your bladder will slowly continue to fill with urine. You don't feel that, but you might feel the urge a little bit later. And so you might be able to start to draw out the time of how long you can hold urine for. So a lot of times when you see a pelvic floor physical therapist like myself, we help you identify triggers and help you with timing for the bladder with a goal of getting to whatever your goal might be. You're like, well, I'm comfortable if I can just hold it for 2.5 hours. And I'm like, okay, you go every hour. Let's figure it out. And this also goes for nighttime urination. So a lot of it is behavioral. So if you have frequency, the first thing you can do is to really ask yourself and tell yourself that not every single urge to urinate means you have to urinate. So if you have to go and you remember you just went at an hour ago, you would ask yourself, can I hold it a little bit longer? Okay. And then you would just wait and draw out until maybe the second urge comes or a second wave, and then go from there. And you would either answer the urge or pat yourself on the back and said, I held it for an hour and 10 minutes. And you would just grow that time, because what you're doing is you're stretching the bladder a little bit, but you're also down training a hypersensitive nervous system that goes to your brain that says, we got to go now. We have to pee now. It's a very hyperactive system, and down training that helps control your brain's messaging to your bladder that tells you that you need to urinate immediately. So those are the 3 topics I wanted to cover today. Like I said, for Physical Therapy Month, the month of October, and just kind of address, the 3 top diagnoses that we see in the clinic as a pelvic floor physical therapist. My information is Imee at ptrenew.com. If you have questions, feel free to email me. You can also, and I'm located in Marin County here in the Bay Area, but if you're tuning in from our San Diego office has also a pelvic floor physical therapist. Our Mill Valley office has a pelvic floor physical therapist. Our San Francisco office has a pelvic floor PT, and I am physically located in Novato. And we can help you answer any and all of these questions. I think Addison, our business manager, she's going to put in the chat box. So you'll see at the bottom, it'll say chat. Both of our email addresses, Imee at ptrenew.com. You can email me like specific questions that are maybe more towards you pelvic floor related, and I can help you navigate. Or you can email admin at ptrenew.com, and that is for if you are wondering like, what office should I contact, or who else treats this, or do you take my insurance? Does insurance cover this? And yes, the answer is your insurance does cover this. So those are the 2 email addresses that are there. And then this recording we recorded this little webinar of ours, so it will be on our YouTube page, and I think it'll be posted there, and I think Addison also put that up on our chat as well. So thanks for tuning in, everyone. I really hope you found our chat, our discussion helpful, knowledgeable, and a good starting point to help you identify if you could benefit from pelvic floor PT. Like I said, please feel free to ask me any questions, email me, because I field questions all the time about whether I should see someone, or, is this something you can help me with? Happy to chat on the phone or via email with any of you. Thanks again for tuning in, and I look forward to chatting with any of these participants, and I hope you all have a great day. Take care.